intestinal fistulas and management. Fistula is any abnormal connection between two epithelial surfaces. The epithelial surface of a hollow viscous or drainage duct in gastrointestinal or GU tract, liver, or pancreas. It can be classified into based on the anatomic and physiological aspects. Anatomic based on the origin and drainage point can be internal or external. Internal, the examples are idiocolic, colovesical. External, the example is enterocutaneous. Physiological based on the output. High output or low output. High output is more than 500 ml per day and low output is less than 200 ml per day. Coming to the pathophysiology of gastrointestinal fistulas, 15 to 25% of them are spontaneous. That happens because of the inflammatory, infectious, cancer, or because of radiation treatment. And the majority, that is 75 to 85%, is post-procedural. The inflammatory causes can be IBD, intra-abdominal abscess, PUD, appendicitis. Coming to the risk factors of post-op fistula, malnutrition, sepsis, shock, hypotension, need for vasopressors, glucocorticoid therapy, associated comorbids, technical difficulties with the surgical anastomosis. Coming to the causes of non-healing spontaneous fistula, foreign body within the fistulous tract, radiation enteritis involving affected bowel, infection or inflammation at the fistula origin, epithelialization of the fistula tract, neoplasm at the fistula origin, and distal obstruction of intestine. Coming to the diagnosis of gastrointestinal fistula, external fistula can be diagnosed by visual confirmation. Suspicious wound drainage can be tested for increased levels of bilirubin and amylase. Fluoroscopy after rectal or oral contrast. The internal fistulas injecting contrast media into one of the hollow viscous, resulting in the opacification of the another viscous. Fistulography, where a retrograde injection method is used, or cross-sectional imaging with the enterography protocol. Endoscopy for the luminal origin of the fistula visualization can also be used. Coming to the management, the initial aspect is the stabilization, which is controlling the sepsis when there is a high output fistula, management of fluid and electrolyte derangements. The output is isoosmotic and rich in potassium. Replacement millimeter for millimeter with balanced salt solution that contains added potassium. Electrolyte determination of the sample fluid at lab and replacement can be formulated accordingly. Next is the establishment of adequate drainage. Pooling of the fistula contents within the abdominal cavity can lead to infection followed by abscess formation and sepsis. Minor surgical procedures such as opening a recent incision or placement of percutaneous catheters can establish adequate drainage. For patients with diffuse peritonitis, abdominal exploration and washout, the goal is to remove the contamination and establish drainage, often with placement of drains during surgery. Diverting enterostomies and surgical feeding tubes are placed when appropriate. Acute postoperative enterocutaneous fistulas decompress through surgical incision. The local wound care with VAC, that is vacuum assisted closure, can also be used. Coming to the nutritional support, well-nourished patients without infectious complications are more likely to experience spontaneous fistula closure and low risk for postoperative complications if surgical repair is required. Malnutrition occurs in GI fistula is multifactorial: lack of protein intake, protein loss through the fistula, underlying sepsis with hypercatabolism. TPN seems to be the natural first choice, but not all to be placed on TPN. Enteral feeding enhances the mucosal proliferation and villus growth through direct and indirect mechanisms. Nutrients in contact with the bowel mucosa provide direct stimulation to enterocyte, and feeding high in glutamine content may be beneficial, as glutamine is the major source of energy for the enterocyte, and release of gut-derived hormones has a trophic effect on the intestinal mucosa. Decision on TPN versus enteral should be hence based on the anatomic and physiological consideration. An initial trial of enteral, if the output increases, the enteral feeding can be stopped. If fistula is in the proximal intestine, distal access to the intestine using a feeding jejunostomy helps in the feeding. Infusion of proximal fistula drainage into the distal bowel has shown to make the fluid and electrolyte management easier, as well as decrease the output of the proximal fistula. Coming to the medical therapy, Somatostatin analogs are used where they act by inhibiting the release of gastrin, CCK, secretin, and other hormones. This inhibition decreases the secretion of electrolytes, water, and pancreatic enzymes into the intestine, relaxes the intestinal smooth muscle, and causes increased intestinal capacity. It also increases the intestinal water and electrolyte absorption. There is no randomized control data on significant effects of octreotide on rates of fistula closure, complications, or mortality, but few studies have shown improvement in the time of closure by converting high output fistulas into low output fistulas. Now, coming to the management of Crohn's, randomized controlled studies comparing anti-TNF agent and placebo on Crohn's patients with draining abdominal abscess or perianal fistula of at least 3 months duration. There is a 68% on anti-TNF agents showed 50% reduction in draining fistulas versus 26% on placebo, and 55% had a closure versus 30% on placebo. Use of infliximab is associated with better outcomes for perianal fistulas than for the abdominal wall, for external compared with the internal, and when given early rather than late. However, infliximab increases the rate of infections following abdominal surgery. Coming to the non-surgical intervention, use of clips, occlusive plugs, and fibrin glue placed endoscopically or percutaneously has also been tried. Now, coming to the surgical intervention, which is the mainstay of treatment, indications include sepsis, abscess, intestinal obstruction distal to the fistula, bleeding. Goal is to resect the involved bowel and restore the intestinal continuity by anastomosis. Timing, there is a window period that is 7 to 12 days after the laparotomy, or a deferred approach that is 4 to 6 months after the laparotomy is taken. In setting of sepsis, at least 6 weeks after stabilization and resolution of the sepsis is the ideal time. Outcomes, mortality is 10 to 30%, and high mortality is seen in patients who are malnourished, previous radiation therapy, complex fistulas with post-op abdominal wall dehiscence, and underlying disease. Now, this is a chart showing the phase of management for intracutaneous fistula. As previously mentioned, various phases: the stabilization phase, decision phase whether to operate or not, and the definitive therapy and healing process. Now, what are the prognostic indicators for spontaneous fistula closure and need for surgical closure? The spontaneous closure is likely when the output is less than 500 ml per day, that is a low output, age less than 40 years, when the patient is well nourished and the site of fistula is in the proximal small bowel, and the cause is the anastomotic breakdown. And the anatomic characteristics include a low fistulous tract and when the duration is acute. But the closure is less likely to occur when the output is more than 500 and the age is more than 65 years, malnourished patients with distal small bowel or colon fistula, and when the cause of the fistula is malignancy, inflammatory or infectious disease, or a complete anastomotic dehiscence. Erosion of mucosa when is shown to have decreased surgical closure, and the duration when chronic is less likely to be closed. Now, in a flow chart, we will see the how the fistula is managed. As previously mentioned, the volume replacement, electrolyte correction, acid-base correction, nutrition support, and collection, drainage, and protecting the skin and applying VAC. Then when adequate drainage is there, and if the drainage is septic, then anatomic and diagnostic studies are required, and anatomically favorable for spontaneous closure if present, then you have either you can choose a distal enteral access or conservative management. When the anatomically not favorable for a spontaneous closure and it is a complex fistula because of prior radiation or cancer, supportive care under the surgical closure is safe. And in case of Crohn's disease, a trial of anti-TNF agent can be used. When there is no adequate drainage, a surgical drainage is required. As mentioned, proximal intestinal or high output fistulas require a distal enteral access, and if it's not possible, then TPN support. If possible, go for a distal enteral feeding and re-infuse the fistula output and reassess. And if it spontaneously closes, or whether a surgery is required, that is done after 6 weeks. This is another chart showing the intracutaneous fistula management. This is the chart from the up to date. Thank you.